Hi, everyone. I'm Hartford HealthCare's Tina Verona. Thank you so much for joining us today. Well, it is Pancreatic Cancer Awareness Month, and as a matter of fact, this Thursday is World Pancreatic Cancer Awareness Day. And who better to talk about it all and join us here live today is Dr. Bret Schipper, Chief Surgical Oncologist at Hartford Hospital and Director of Oncologic Surgery at Hartford HealthCare. Thank you so much, Dr. Schipper, for joining us.
Thank you for having me.
We appreciate it. Let's just start out first with statistics in terms of pancreatic cancer. What are we seeing in terms of any trends? Is it increasing at an alarming rate or a steady rate or decreasing? What are some of the numbers?
Yeah, so pancreatic cancer in general is becoming more prevalent. It tends to be a disease of older individuals, average age around 70, somewhat more common in men. And unfortunately, we haven't been able to move the bar very much in pancreatic cancer. Unlike other cancers like breast, colon, ovarian, where we've made major breakthroughs in treatment and screening, we really haven't found that holy grail of early detection or treatment to really improve survival. So the survival for pancreatic cancer still sits below 10% at about 9%. And that really hasn't changed much. Back in the 70s and 80s, it was about 3%, and we've only gotten to 9%.
Right.
So still a lot of work to be done.
Yeah, especially when you hear in other cancers like breast cancer, I mean, the numbers are just decreasing at a very rapid rate because of those screening tools. In terms of someone who may be at high risk, how would you categorize someone at high risk to maybe perhaps get further testing if they are at high risk for developing pancreatic cancer?
Sure. I think that's one of the areas we're working a lot on these days is looking at research to try and determine who is high risk and who should get formal screening to evaluate themselves to see if they do have a pancreatic cancer. We know that pancreatic cancer, if found early, can be treated successfully, but unfortunately, a lot of pancreatic cancer is found late. So the data now shows things like early onset diabetes. If you become a diabetic later in life, that can be a big red flag that there could be a marker for pancreatic cancer. There are other genetic predispositions, things like BRCA, which you may hear a lot about in the breast world or ovarian world. That can put you at an increased risk. So there's other genetic markers that can put you at increased risk as well. Also family history. If you have multiple family members who have been diagnosed with pancreatic cancer, that could show that you have a higher increased risk of developing pancreatic cancer yourself. And for those patients, we do recommend screening with either imaging or other tests to see if you do have any signs of early pancreatic cancer.
Blood tests too, can that be found too with blood tests, or is it all imaging?
Most of it revolves around imaging. We do have a blood test with a tumor marker that can sometimes be elevated in pancreatic cancer called CA19-9. However, it is not always elevated in pancreatic cancer. There are patients who have pancreatic cancer and have a normal CA19-9 level. We do test everybody for it if they have pancreatic cancer, and we can use that as a marker. So if they have pancreatic cancer and their number was elevated and they go through successful treatment and are cured, and the number falls back down after treatment, we can use that as a marker sometimes. If we start to see that creep back up, that could be concerned that the disease is coming back. But really no blood test that we can use to screen people who are high risk.
All imaging. An anonymous question we had, what is the pancreas and what does it do?
Sure, that's a great question to start with. So the pancreas is actually a very important organ, and it sits deep in the abdomen, kind of behind the stomach, against the spine and some major blood vessels, and it has two main functions. Some are what we call exocrine function, which are creating juices to help you digest the food, different enzymes, and the other is endocrine function, which is based around controlling hormonal things like blood sugar. So that's why we mentioned diabetes. If those cells start to develop a cancer, it can throw your blood sugar control out of whack and cause you to create diabetes and can be a marker. Also, depending on where the tumors are, they can block up the pancreas. So if the pancreas, if you can imagine, it has a pipe that runs through the middle of it that empties into the intestine, and that pipe drains the digestive juices. If a tumor is formed and blocks up that pipe, you can have trouble with the digestive juices draining out, and you can have trouble digesting food and things like that. So those are the two main functions of the pancreas.
And would that be a symptom of if you're having trouble digesting? Could there be, whether it's a tumor or, I want to talk about cysts too, that can actually develop into cancerous lesions in the pancreas. Is that correct?
Yeah, so I'll take the first part first around markers for people who could be developing pancreatic cancer. One of the things we always talk about is jaundice. And jaundice is yellowing of the skin, yellowing of the eyes. You can also have clay-colored stools or light-colored stools or really dark urine. These are all signs that the bile pipe is getting blocked and the bile is backing up into the liver. So I mentioned the pancreatic duct, which is the pipe that runs through the pancreas. There's also the common bile duct, which is the pipe that takes bile from the liver into the intestine as well. And that pipe runs right through the head of the pancreas and joins up with that pancreatic pipe and then empties into the intestine. The pancreas has multiple parts. It has a head, a neck, a body, and a tail. And if you get a tumor in the head of the pancreas, that tumor can often compress those pipes. And if the pipes are compressed, they won't drain. That bile then backs up and you turn yellow. We always talk about what we call painless jaundice, meaning you become jaundiced but you don't have any pain. That's a very severe indicator that you could have an early pancreatic cancer or other major issue going on with either the pancreas or the biliary tree, and that is something you should urgently seek care for. So that's one of the most common things. Occasionally you'll have abdominal pain as a marker. That obviously can be from lots of different things. It also depends where in the gland you get the tumor. So if you get the tumor in the head of the gland, that's where all that pipe work is that can get blocked up and cause symptoms. However, if you get a tumor out in the tail of the gland or the back end of the gland, there's really not much there to push on. So those tumors can sometimes grow to a larger size before they're even detected.
So, you know, you hear in breast cancer, if you have a cyst, doesn't become cancerous. But in pancreatic cancer, it certainly can. How does that happen? How does that evolution happen from going from perhaps a benign cyst to a cancer?
Sure. So pancreatic cysts, there's been a lot of research on those. And for the most part, like you said, like most other cysts in the body, the majority of them we can watch. But we have found that there are certain criteria in these cysts that if they meet these criteria, they are at higher risk for turning into a cancer. Some of those criteria are things like size, so if they're over a certain size. Also, if they're involving that main pipe we talked about, there are also side pipes that feed into that main pipe, but if the cyst is in that main pipe, we know those are at higher risk. Also, what the cyst is filled with. So sometimes you can have simple cysts, which are filled with just like water, very simple, thin fluid, or you can have what's called a mucinous cyst, which is a thicker fluid. We know that those mucinous types have a higher risk of turning into a cancer. There are also other things we can see on imaging called nodules or mural nodules that are within the cysts. All these types of things are markers to say these cysts are at higher risk of transforming into a cancer and should be removed. We also have ways of testing the fluid within the cyst with genetic tests. And that can also tell us if they have certain genetic mutations that put them at higher risk. So there's a lot of work around pancreatic cysts on determining which should come out and which shouldn't.
And then as far as surgical procedures for, I know one of the things that was interesting to talk about and how you remove these cysts surgically. Are there any, let's talk about some of the surgical methods in terms of removing either a cancerous lesion for pancreatic cancer.
So again, it really depends where in the pancreas the lesion is. The operation differs if it's in the head, if it's in sort of that body or the tail. In general, we can offer these procedures in either a minimally invasive form, which means laparoscopy or small incisions or even robotics in some cases, versus an open procedure where we actually make a much larger incision. But essentially, we want to remove the tumor. And if it's in the back end of the pancreas, or what we call the tail of the pancreas, that's a little more straightforward in that we just cut off the back end of the pancreas and usually remove the spleen as well, because the lymph nodes that drain the pancreas also sit and drain the spleen. So in order to get a good cancer operation, we remove the tail of the pancreas and the spleen. That operation has lower risk profile. We're not messing with all the major plumbing of the GI tract. However, when you get into the head of the pancreas, where all those pipes are coming together that I spoke about, that operation is then called a Whipple operation, which is a very big operation. And in that operation, we have to remove things like the head of the pancreas, the first portion of the intestine called the duodenum, the common bile duct, which was the pipe we mentioned, goes in there, as well as part of the stomach sometimes.
You're basically taking it apart and rebuilding it and putting it back together,
Correct.
the stomach.
I always tell the patients it's basically rerouting all the major plumbing of your GI tract in an operation like that. But we do it because if we can remove all the cancer, we give them the best shot at a potential cure. You know, again, here we're at Hartford HealthCare, we're really pushing the envelope on cutting-edge technologies, including minimally invasive techniques as well as robotics, to have the patients have a quicker recovery and a quicker return to their normal life.
We'll get into more of that, but I want to get to William's question on Facebook. He asks, are there any behavioral factors that have been proven to be related to pancreatic cancer? Drinking, diet? All good question. Thanks, William.
Yeah, thank you, William. That's an excellent question. So I think one of the biggest factors when we think about pancreatic cancer are some are factors we can change and some are factors we can't. So to answer your question, I would say smoking is probably one of the bigger ones that people have shown some linkages to higher increases in pancreatic cancer. Obesity sometimes has been shown to cause an increased risk. So really, those are kind of the two big ones as far as factors that you can influence to decrease your risk. Some of them you can, obviously. Your family history, your genetic profile, those are things you can't change. But things like smoking and drinking and obesity are things you can change.
Paula on Facebook asks, my husband died of pancreatic cancer 8 weeks after he was diagnosed. What is considered high risk? Paula, thank you for the question.
Yeah, thank you, Paula. I'm sorry for your loss.
Yeah.
And unfortunately, not uncommonly, that's what we see. As we kind of touched upon, we don't have a lot of good screening measures. So unfortunately, there's a lot of patients who present to us with fairly advanced disease. By the time they reach us in our office, the cancer has already gotten to the point where we can't remove it. And at that point, the options we have are more around chemotherapy and radiation and other trials and things like that. So sometimes, unfortunately, the patients come to us when the cancer has already spread to the point that there's not much we can offer. And unfortunately, sometimes those patients have lost the window where we can really do something and unfortunately succumb to the disease in a quicker fashion.
And it is unfortunate with other types of cancers, with, colonoscopies, there's screenings, there's mammographies, there's ultrasounds, there's so many screenings to help with that early detection. Unfortunately, there isn't with pancreatic cancer. That is obviously the goal and the hope one day. Are we any closer to getting to a point where we could diagnose pancreatic cancer or have some type of screening that could detect it before the onset of symptoms when it's too late?
Sure. I mean, that's really the holy grail of what we're all waiting for, is how do we find out who is at higher risk and how do we screen them correctly, and also figure out a way where we can catch the people who aren't high risk and just unfortunately develop this disease. Unfortunately, we really haven't moved the bar very much on that. I'd say the biggest push in the last few years has been around high risk. So at least we're trying to identify
that
who
population
is at higher risk so we can screen them. But unfortunately, unlike colonoscopies for colon cancer or mammography for breast cancer, we really don't have that gold standard test to find people. Sometimes people are lucky in that they'll get a CAT scan for something completely unrelated.
Right.
And we find it, and that's a lot of the times how we find pancreatic cysts, or patients will get a scan for whatever, and then we find these cysts, and then they get plugged into our cyst program for monitoring and further treatment and evaluation. But unfortunately, like your husband, sometimes they're just come in when the tumor has progressed to a point and there's not a lot left we can offer. Here at Hartford HealthCare, though, we are very aligned with Memorial Sloan Kettering, so we are very much on the cutting edge of treatment options available. We work very closely with Memorial Sloan Kettering in access to their trials, access to their experts, and really standardizing our care to the same level at Memorial so that patients can feel confident if they come here to our center, they're getting the same standard of care that they would be getting at Memorial.
And part of having access to all of those clinical trials and access to that research to be on the leading edge and pioneering and paving the way to what's to come in terms of how we treat pancreatic cancer. Another interesting thing that I want to mention is the multidisciplinary team approach that you have and the Tumor Board, where you meet quite frequently. It's a group of specialists like yourself and all meet around and discuss patients' cases, because it's always like when you have all these eyes looking at a patient's case, everybody has different opinions and different ways of looking at things. So that can be extremely valuable in terms of plotting out a treatment course for each patient.
Absolutely. And that's something we really strive for here at Hartford HealthCare, is really personalized care for the patients and the patient experience and making sure they're getting the best possible treatment options available. And what we've developed is a multidisciplinary tumor board that meets once a week at this point, and we try and present every new pancreatic cancer that comes to us. And the tumor board is made up of all the specialists who treat pancreatic cancer. So we have medical oncologists, we have radiation oncologists, we have surgical oncologists, we have pathologists, we have radiologists, we have nurse navigators, who I'll mention more in a bit what their role is. But anybody throughout the continuum that treats pancreatic cancer is in the room, and we present these cases, and as a group come up with a consensus as to how these patients should be treated. In pancreatic cancer, it's really a multimodality treatment option situation where we can use things like surgery, we can use things like radiation therapy, and we can use things like chemotherapy. And the real question is, in what order should these things be done? And that paradigm has changed over the years somewhat. In the past, it used to be more about if you can cut it out first. And now there's been more data to show, well, maybe we should give chemotherapy first. So that paradigm changes, and by having all the experts in one room to discuss this, it really makes sure that the patient is getting the optimal treatment for that patient, and then that decision is brought back to the patient and they go continue down their course of care.
Extremely valuable. William has a follow-up question. Have there been successful transplants of the pancreas? Is that a way to respond to cancer of the pancreas? He adds, this doctor is one of the best communicators I have heard on a webinar. He is terrific. Well, thanks, William, for the compliment. Good job.
Thank you very much, William. I appreciate it. So you bring up an interesting question around transplant. And transplant is a tricky field with cancer, because one of the things around transplant is if you're going to get a transplant, one of the other things that go with that is immunosuppression and lowering your body's own natural defense mechanism so that you don't reject that transplant. And typically cancer is a contraindication to immunosuppression because you're now blocking your body's ability to fight the cancer as well. So typically we don't use transplant in the setting of pancreatic cancer. However, we do offer pancreatic transplant for other diseases, but not specifically around pancreatic cancer.
Thanks for watching, William, and for the great question. Samantha asks, is there a certain age that you have more at risk for getting pancreatic cancer?
So as I mentioned earlier, there's not a specific number, but pancreatic cancer does tend to develop more in the older population. That being said, I've treated plenty of 40-year-olds and middle-aged folks, but I'd say on average it's probably in the 60 to 70 year range.
Okay. Another question on Facebook from Laura. Are there different types of pancreatic cancer? Thanks, Laura.
There are types called adenocarcinoma, which is your sort of garden variety pancreatic cancer. But then there are other what we call neuroendocrine cancers that can secrete different hormones and different things. So there are different types. The treatments do vary somewhat depending on the type. And I would say the garden variety is the adenocarcinoma variety.
Question from Jeff. Are there any long-term effects from having had the Whipple surgery?
Yeah, that's a great question, Jeff. And yes, as the short answer is, it is somewhat patient dependent. So I have a lot of patients I'll do the Whipple procedure on who do great. And you would think, we trimmed a toenail and they do fantastic. Other patients, though, do have side effects from it. Some side effects you can have are things like we mentioned the exocrine and endocrine function of the pancreas. So if we remove a section of pancreas, you now have less gland and less ability to create those enzymes or hormones. So sometimes you can have issues creating enough digestive juices to digest the food. If that happens, we do have those enzymes in pill form we can give you. You could have issues around diabetes. If you weren't a diabetic before the surgery, you could then become a diabetic. Or if you were diabetic before the surgery, your diabetes can worsen. Obviously, we have ways to treat diabetes. Other things that can happen is the Whipple operation has two subtle varieties, where in one variety we remove a portion of the stomach and in another variety we don't. That's called a pyloric preserving or not. And anytime you start operating on the stomach, you can have troubles with the stomach functioning. It can have trouble squeezing the food through some of the new connections we make. So that's called gastric dysmotility. And we have different medications and ways to manage that. Those are some of the bigger complications. The other thing we worry about anytime we do a Whipple operation immediately after surgery is a leak. It's kind of like plumbing. You put two pipes back together. on occasion you can have a leak. If something like that happens, that can require further surgery or procedures.
We're getting a lot of questions. Helen asks, what cutting-edge procedures are you doing when the cancer has metastasized? And she has a follow-up question to that.
Sure. Unfortunately, when the cancer is metastasized, surgery then comes off the table. At that point, the cancer has left the pancreas and the surrounding areas. So doing this big operation, as I talked about, to remove it isn't going to add any benefit. So at that point, we move into the chemotherapy and the radiation treatment options. And after that, we move into different trials that may be available here locally or in other institutions around the country.
Yeah, and then she says, what hospitals out of state are concentrating on pancreatic cancer research?
Yeah, so there are, most of the big academic centers, the places like the Memorial Sloan Ketterings, the MD Andersons, those kind of places are working on it. But even locally, there are physicians who are doing work around diabetes and pancreatic cancer and other work. So I think there are the major academic places, but there are other places as well that may not be doing bench-side research, but maybe doing clinical research.
All right. Oh, I like this one. B says, oh my goodness, this is the doctor that did my last surgery. He was amazing. Thanks, B, for that comment.
Thank you, B.
You are quite popular. Mindy asks, how is pancreatic cancer screened?
Yeah, so again, good question, Mindy. And again, unfortunately, we don't have a lot of great screening. Typically, if you were to get a scan for something or you presented with the painless jaundice or other things that I spoke about, you will usually start with a CAT scan or an MRI. To get a good evaluation of the abdomen. The typical next test would be something called an endoscopic ultrasound, which is performed by our GI colleagues. Again, in pancreatic care, it's really a multidisciplinary sport, and we work very closely with our colleagues in GI, in medical oncology, in radiation oncology, and it's those GI doctors that perform the endoscopic ultrasound. And what that is basically an upper endoscopy, kind of like a colonoscopy, but from the top side. And at the end of the scope is a little ultrasound probe. And if you can imagine, the pancreas sits right behind the stomach. So they can put that probe into the stomach and using the ultrasound, see through the stomach into the pancreas and find that tumor. They can then, using a very fine needle, take a biopsy of that tumor so that we can get pathology and confirm it is in fact a pancreatic cancer. They also give us the ability to look at the surrounding structures to see if any of those are involved with cancer. One of the decisions that we have to make as a surgeon when we get these patients is, are they resectable or not? And by that what I mean is the tumor involving any of the key vascular structures mostly that are non-resectable or that we can't take out? If the tumor is involving these structures, then we usually don't offer surgery up front. The endoscopic ultrasound along with CT or MRI is what we use to make those decisions. Pancreatic cancer, usually when it comes to us as a surgeon or when it's presented at these multidisciplinary groups, falls into one of three categories. Either clearly resectable, meaning the tumor is small, confined to the pancreas and not involving any other structures, or it can be borderline resectable, meaning it's starting to invade some of these structures, but it hasn't spread distant. Or it can be completely unresectable, meaning it's spread to a distant place, or it's completely encasing some of these critical structures. If it falls into that clearly resectable, then we have the conversation of should we do surgery first or should we do chemotherapy or other treatments first. If it falls into that advanced stage, then it's usually no surgery and just chemotherapy or radiation. When it falls in that borderline stage, we then usually will recommend some sort of chemotherapy or plus minus radiation to see if we can shrink it back to get to that resectable stage.
I think this is critical when the tumor board really comes in handy in terms of discussing everything, every possible course of treatment that you could be taking to sort of chart that patient's journey.
Absolutely.
So I think that's...
It's critical to have the radiation oncologist in the room to look at that scan and say, I think I can get that with a good dose of radiation, or I can't because of X, Y, and Z. And to have everyone at the table at the same time really gives that patient the knowledge that they've had the expertise all in the same room, all review their case and come up with a plan together.
Yeah, absolutely. Willow asks, what is the stage 4 life expectancy generally?
Yeah, so unfortunately when you get to stage 4, that means the cancer has spread outside the pancreas, is typically out into places like the liver or other places in the abdominal cavity. And then we get into, again, We have some patients who say, I want to still do everything, and they get plugged into the medical oncologist for chemotherapy. Occasionally, sometimes depending on what the metastatic disease is, they can get radiation. Other patients sometimes say, you know what, I know the survival isn't good, my time is limited, I'd rather not do chemotherapy, and decide they're more focused on quality of life.
Right.
And for that, we have excellent palliative care doctors here who their whole focus is making sure that people are comfortable and have a good quality of life while they're battling these end-stage diseases. Here at Hartford HealthCare, we have a fantastic team that we work with very closely, and even if they're not stopping treatment, even if they're along the course of treatment, we frequently plug them in with these folks. Palliative care doesn't necessarily mean end of life. It just means patients, with cancer or different diseases who we're trying to help make sure that their quality of life is the best it can be and comfortable.
Yeah, and that brings me up to when you do get a diagnosis of pancreatic cancer. I want to talk about the Nurse Navigators because hearing just the words, you have pancreatic cancer, and if it is the stage 4, God forbid, you have nurse navigators that are with the patient every single step of the way, because you're dealing with the emotions of it all, and it's can be tricky and confusing to who do I go to next, but the nurse navigator is there to take them through this journey.
Absolutely. Unfortunately, I'm usually the one giving these diagnoses, and I see on the patient's face, you can see how scared and confused they are. We're giving them a lot of information all at once, and it's a lot to take on. And usually once someone is diagnosed with cancer, it then unfolds this whole cascade of events, including different imaging, different appointments with different doctors, all sorts of different things, and it's really important to have someone help guide those patients through that journey. Here at Hartford HealthCare, our focus is the patient experience and making sure that they are getting the best experience in the state around their treatment. And we have these patient navigators who help the patients along this journey. They help them coordinate their appointments. They help them know where to go and when to go. They make sure none of the balls are dropped along the continuity of care to make sure everything falls seamlessly and the patients move down their course relatively effortlessly from a patient perspective.
Yeah, it's a huge component. Jeff asks, do you see many cases that involve ampullary cancer? If so, is surgery normally required?
That's a great question, Jeff. So you bring up a good point of there are when you get into the real details of pancreatic cancer, there can be different places where you get them. And the ampulla, which Jeff refers to, is that point where the pipes come together. So you have the common bile duct come down, the pancreatic duct, and they both meet at what's called the ampulla. And what that is a valve or a sphincter that opens and closes into the intestine and lets the juices out. That is a common site where you can get these tumors, in the ampulla. The treatment there is a Whipple operation, which we talked about kind of already a little bit. So we treat those all, whether it's an ampullary cancer or a head of the pancreas cancer or a distal common bile duct cancer where it comes into the pancreas. The treatments are relatively the same for all those. There are sometimes some subtle nuances that'll differentiate things. But usually anywhere in that head area, whether it's an ampullary, whether it's a head of the pancreas, whether it's a distal common bile duct, you're pretty much looking at a Whipple operation to get it out.
Helen has another question. Is there a department at Hartford Hospital that the patient can work with to find out about those nationwide trials?
Absolutely. If unfortunately you or a family member have pancreatic cancer, you usually have a relationship with an oncologist or a medical oncologist who is the person who's directing the chemotherapy or medical care. Those are usually the best people who have access to these trials. So here at Hartford HealthCare, we have what we call these disease management teams, where we get together with folks even outside of the tumor boards. Now we're getting into higher level groups who deal with all bigger aspects around cancer care around the GI world, where we talk about what are the latest trials out there. Is this a trial we want here at Hartford HealthCare? And is this a trial we want to bring into our patients here, where we kind of vet all the things going on around the country and decide what we want to make part of our program? So the short answer is my recommendation to get access to trials would be to either contact our navigators who, again, help patients along these journey, or speak to our medical oncologists who have the closest ties to a lot of these trials.
Well, and I think too, also the partnership, the relationship with MSK, there's over 800, clinical trials that they have at any given time. So to be able to tap into that is extremely valuable in terms of for pancreatic cancer.
Absolutely. Our relationship with MSK is really, priceless. It's an incredible opportunity to have their expertise here in Connecticut.
Right.
We follow the same standards of care that they do. They take part in a lot of our conferences. So for instance, at these tumor boards, we have tumor boards sometimes for really complex cases where we'll have the Memorial Sloan Kettering doctors teleconference into the conferences so they can give their, opinions right there on the spot of, hey, we may have this available here, or this is what we think. So we have their expertise directly involved in the patient care.
And even in treatment too. I mean, for the patient wouldn't have to necessarily travel to New York City to get that treatment. You can get that treatment right here at Hartford.
Absolutely, and that brings up another good point, that we have facilities throughout the state really at this point. So you can elect to get your care. It doesn't necessarily have to be here at just Hartford Hospital or one of the other acute care hospitals. We have lots of beautiful new cancer centers we've built throughout the state where you can get your chemotherapy and still remain close to home, where you can see your doctors and not have to necessarily drive into Hartford or drive to other places. Again, our goal is to keep your quality of life and your ability to maintain your daily activities as close to normal as possible through this journey. So by allowing you to have your care close to home, we feel that really gives the patient a lot of benefit.
That access to coordinated clinical care is so vital. Mindy has a follow-up question. Are there always early signs?
That's a great question, Mindy, and unfortunately there's not. That's really one of the major problems around pancreatic cancer, is that there are not always signs. And unfortunately, some patients don't have their tumor found until it's gotten so big that it's caused a major problem that causes some sort of symptom that gets you a CAT scan and then it's found. Patients who have the disease, again, in the head of the pancreas, where all that pipework is, tend to show symptoms earlier because there's a lot of more critical structures there that can be involved that can throw up the red flag of warning. But unfortunately, no, there's not always warning signs when you have pancreatic cancer.
We've talked a lot about pancreatic cancer. I want to switch gears just a little bit and talk about the Hipec procedure, which is something that you do for different types of abdominal cancers. And it's a really interesting procedure that you're putting chemotherapy in, warming it up, and removing the cancer. Explain how that Hipec procedure and what it stands for first. I'll let you explain that.
So Hipec stands for heated intraperitoneal chemotherapy, and it's a treatment that's been around for a while, but is only done in select centers. And it's really for patients with stage 4 cancer, so metastatic cancer, for certain types, including appendix cancer, colon cancer, ovarian cancer, something called pseudomyxoma peritonei, or something called mesothelioma. It is a procedure that really has two parts. The first part is the debulking part, or being able to remove all the visible cancer. Once we've removed all the visible cancer, we then put hot chemotherapy at about 41 degrees centigrade into the abdomen and wash it around for 90 minutes. And the purpose of that is to try and kill any microscopic disease that may be left behind. It's a procedure that I offer here at Hartford Hospital, and I'm only one of about 2 or 3 surgeons in the state that offer this.
And so this is a surgical procedure. It's not something that it's like chemotherapy. You have to go back for treatments. It's a kind of a one procedure type event, right? And
we can sometimes do it more than once. So there are patients who I have done it to who then become disease-free for a period of time. And then sometimes a couple of years down the road, the cancer can come back. And sometimes we can go back and do a second round of Hipec. However, typically you're right. Typically it's done at the time of the surgery and then that's it.
And then the type of chemotherapy that you use can differentiate between patients. Is that correct?
Correct. Depending on the disease type, we use basically 2 major types of chemotherapy. One is called mitomycin C, and we use that for most of the GI, the appendix, the colon, and that's very well tolerated, really minimal to no side effects. However, for things like ovarian cancer or mesothelioma, we use a platinum drug. The platinum drugs can be a little more toxic to the kidneys and kind of have a higher side effect profile.
I was going to ask you, what is the recovery like, and then in terms of side effects?
So the recovery really depends on the debulking, because that's where the operation can vary. So if patients have minimal abdominal disease, we may only take out the primary tumor and maybe the omentum, which is just like the fatty curtain. However, if they have extensive abdominal disease, we may start to remove things like the spleen and the stomach, or a portion of the stomach, the diaphragm, multiple intestinal resections. Obviously, those patients have a higher risk profile than someone who we just do a very small surgery on. So it really depends on the debulking phase, how risky the procedure is.
How prevalent are these types of cancers related to the abdominal cavity, and how often are you doing the Hipec procedure?
Yeah, so it really depends on the type of cancer. There's been a lot of studies going on right now around ovarian cancer and Hipec. We are members of a trial through Memorial Sloan Kettering, giving our relationship, looking at recurrent ovarian cancer and using Hipec in that setting. There's also been some new recent data showing that Hipec may show benefit in primary ovarian cancer, so in using it as a modality treatment for patients newly diagnosed with ovarian cancer. The gold standard for Hipec has really been around things like appendix cancer. And in those situations, if I have a patient with early appendix cancer who I'm able to do a complete debulking and go ahead and do the hot chemo, those patients typically don't even go on and get chemotherapy. So it really does change their treatment course, and those patients can do quite well.
William has a follow-up question, which I want to get to. If CAT scans or MRIs were not costly, would a person at high risk of pancreatic cancer be advised to get one, and would that raise the survival rate? Thanks, William.
Thank you, William. So, you bring up a great question on, yes, we know CAT scans and MRIs can pick up a pancreatic cancer, but you also raise the point that they are costly. They can be significant costs, especially depending on people's healthcare coverage. And also there's, especially with CAT scans, there's radiation exposure, which, a basic CAT scan every now and again doesn't add a lot, but over time, radiation exposure obviously is bad. So, it would be great if everybody could just get a CAT scan once a year and just get a quick scan and make sure there's nothing going on anywhere. But unfortunately, that's not the reality. We would bankrupt the healthcare system if everyone in America just started getting random CAT scans and MRIs. So what we're really trying to focus on now is identifying the population that is at higher risk, because those patients we know are at higher risk, and then the cost-benefit ratio adjusts, because then we know we have a higher chance of picking up something that could save someone's life. So really that's where we are right now, is identifying the high-risk patients, and then those patients, we are getting things like CAT scans or MRIs or endoscopic ultrasounds to evaluate them for any early signs of pancreatic cancer.
Mindy asks, why wouldn't routine CT scans be preventative for high-risk patients like colonoscopy or mammogram screenings?
So, and thank you, Mindy, for the question, and that kind of leads back to the previous question is, CT scans are what we're starting to use for the high-risk population. We are offering them potentially CAT scans or MRIs, or even potentially sometimes endoscopic ultrasounds have been included in studies for that patient population. But unfortunately, it's not standard of care or cost effective to just blanketly scan everybody for the chance of cancer.
We talked about diabetes earlier. If somebody develops diabetes later in life, is that a red flag? Is that something that could be enough to say we're going to look at further screening perhaps for pancreatic cancer?
Absolutely. There are studies going on right now trying to answer that exact question, because we have found a correlation between new onset diabetes and newly diagnosed pancreatic cancer. There is some connection. We don't know exactly what it is, and we don't know exactly how to modify it yet, but we know there's something there, and there are active trials and studies going on now trying to figure that out. But yes, I think the key is if you fall into these categories, is seeking consultation with folks here at Hartford HealthCare to be evaluated to see if you do have a family history or other factors that would then make you available to get these further testing. I recently did a public speaking event in Wethersfield through Hartford HealthCare and one of the non-for-profits where we had the community there, and we gave a talk on pancreatic cancer, and I can't tell you how many people came up and said, oh, I have a couple of family members who had pancreatic cancer, what do I do? And we plugged them into our genetic counselors here at Hartford Hospital, and Hartford HealthCare, I should say, because we have genetic counselors throughout the system, where they can see you and take a very detailed family history and try and determine if you are in these high-risk categories, and then plug you in to get the appropriate screening and risk.
Well, and that's why doing those community talks and doing this one like we're doing on Facebook is so important to educate people, because they just may not be aware that, well, you don't think about it. If you have a family member with pancreatic cancer, it might not be something that would prompt you to think, I could be at high risk. So I think education is so important. Jeff has one more question going back to his question about regarding side effects from the Whipple. Does reconstruction of the plumbing typically last for a long time? Does it hold up?
Great question, Jeff. And I think the short answer to that is it depends. There are patients who have these symptoms early on in their postoperative course, and we hope, and usually those symptoms will resolve over time. However, there is a small percentage of people that unfortunately do have long-term sequelae from these operations and can struggle with some of these issues for an extended period of time.
So let's go back to kind of that earlier question. We were talking about high risk. What should people, viewers that are watching, know if they are at high risk? What are what's the criteria, if you will? What would a person be concerned with that I could be at high risk?
Sure. I think, the number one thing is family history. If you have more than one family member who's been diagnosed with pancreatic cancer, there's a very high chance that there could be a genetic issue there. New onset diabetes, we talked about. Painless jaundice, all of a sudden starting to turn yellow. Unfortunately, those are kind of the biggest things we have right now. Obviously any significant abdominal pain, back pain, those can be a signs of advanced pancreatic cancer. However, those can be a sign of
Just
lots of
about
other
anything,
things
yeah.
as well. But really, as soon as you realize something's not right, it's so important to just seek a medical evaluation to make sure you're not missing something. Because especially in pancreatic cancer, we know that if it is caught early, it makes a huge difference in survival. So we have Nurse Navigators who you can reach out to here at Hartford HealthCare who can help plug you in to the various physicians. We have genetic counselors here at Hartford HealthCare who you can connect with to get that family history taken and see if you are at higher risk. And we have world-class surgeons and medical oncologists and radiation oncologists and GI doctors, any one of which can plug you into the system.
Mindy asked, could you repeat one more time who is at high risk? So I think we pretty much touched on all those points in
Sure.
terms of who is
Sure.
at high risk.
Family history being a big one, multiple family members having pancreatic cancer, painless jaundice or noticing any yellowing of your eyes, yellowing of your skin, really dark urine or really light clay-colored stools, or significant abdominal pain.
I always like to end on, what does the future hold for pancreatic cancer patients? Any kind of hope out there?
Yeah, I think, there's been a lot more focus recently on pancreatic cancer because the statistics are not good. We haven't really moved the bar. So there's been a lot of efforts lately to really try and focus in on things like high risk, really trying to identify who is at high risk and how do we screen those patients and follow them long term. Around the chemotherapy world, we are now using some different drugs that have been shown to have better effects. So trying to move the bar on the chemotherapy agents, using genetic profiling of the tumors and of the patients to try and create designer, medications and, immune trials and all these different things to help patients fight the cancer. And really just education and making sure you're at a center that offers the cutting edge care available to make sure that no, box goes unchecked and no option is not presented to you, and being at a place like Hartford HealthCare where we have all the things you would need.
Absolutely. A lot of research going on in other parts of the country, including right here at Hartford Hospital, Hartford HealthCare, with our partnership with Memorial Sloan Kettering. Hopefully one day may lead to getting those numbers up in terms of decreasing the amount of people diagnosed with pancreatic cancer. Dr. Bret Schipper, I can't thank you enough for joining us today and your expertise. It has really been educational and enlightening. We've had a lot of great questions from viewers out there. Thank you, as always, so much for watching and for asking those important questions. For more information, feel free to call our Cancer Connect line at 855-255-6181. Again, that's 855-255-6181. As always, thanks so much for watching. I'm Hartford HealthCare's Tina Verona. We'll see you soon.